chiedo a Wendy Levinson di recarsi al pulpito. Wendy Levinson ci introdurrà e ci illustrerà le misure a livello internazionale che come impatto che Choosing Wisely ha avuto nei paesi dove questa attività è iniziata e si sta sempre più sviluppando. Wendy.
Well, hello again. I'm sure that many of you have you listening to these presentations about Choosing Wisely, ask yourself the question, so what kind of impact is it having? And what I'd like to do in these few moments that I have with you is to really describe a framework for thinking about how we measure overuse and the impact on overuse. I'm going to provide some examples from the Canadian context and also describe some of the growing measurement efforts in our international collaborative. So to begin, I want to raise something that you've heard these words before, and this is to talk about culture. Because in North America, more and bigger is better. And actually half the cars sold in the United States are SUVs. So that's what they drive around in small villages. But we're trying to tell people to drive cars that look like this, that are more economical and energy efficient. And this is a culture change. And I think it's really important to think about measuring Choosing Wisely in a broad sense as a culture change, not just asking the question that I think we all race to, which is what's the impact on utilization? So here are some thoughts about the framework. We know to start with that the situation in North America anyhow, is that about 30% of all the tests and treatments that we order, and this is a number I can give you in Canada and in the United States, and I'll share more about this in a minute, about 30% of what we order is not necessary. In fact, it might be harmful to patients. So that's a large amount to work with. So in general, we think that this problem can't be fixed by any one professional group. It needs to engage all health professions. And this morning I used the word clinicians, but just so you know, in North America, clinicians would include nurses, pharmacists, all health professionals. So I think all health professionals need to participate. We work in organizations, hospitals, clinics, and those organizations also have a role to play in this problem of overuse. We heard a lot this morning about the public and patients. I'm not going to spend a lot of time on this, but we've spent a lot of effort with our medical students, and I can maybe talk about that a bit in the question and answer period. And of course, governments and payers have an important role, but like I said earlier, we don't think they can lead this. It needs to be led by the health professionals. But what about the outcomes? What are we seeking? Well, there are several levels of outcomes. First, there's immediate outcomes. Who knows about Choosing Wisely? Do health professionals know? Do students know? Is the public aware? In Canada, we've done surveys, and after working about 3 years, about 90% of physicians are aware of Choosing Wisely, and 11% of the public are aware of Choosing Wisely. So that's still low. We have a lot of work to do, but you can't move forward unless people begin at some level of understanding of what it is and why overuse is important. The second intermediate level, of course, and this is what we hope for, is that the physicians or clinicians won't just know about the recommendations, they'll put them into practice. And in fact, in our recent survey, the clinicians told us that 42% of clinicians said that they use the recommendations in practice very frequently, or occasionally. So we think we're making progress into some of these intermediate outcomes. And of course, the organizations in which we work also need to be engaged in helping to implement Choosing Wisely, putting it into practice. And of course, the long-term goal we care about is that we would decrease the use of unnecessary tests and treatments and procedures. But I want to underscore that nobody on our team thinks that we're going to do that overnight. And one of the challenges we have in choosing wisely, certainly in Canada, is that the people who've supported us want those long-term results as fast as we can deliver them. And we know we have a process of changing culture that takes time. So with that as a backdrop, let me share some of what we're measuring. So given that we have this, we see this as several types of outcomes, we've tried to look at measuring a variety of outcomes. Provider awareness and attitudes, that's logical. Patient perceptions and attitudes. Provider behaviors, are they actually influencing low-value services in some settings? And changes in the health systems, like in the hospitals in which we practice. And we're trying to measure at all of those levels. So I'll give you some examples. In terms of physician attitudes, I mentioned that 88% in a recent survey that we did say they were aware of Choosing Wisely Canada, that 42% used the recommendations, but many of them told us that we needed more patient tools to help patients make informed choices, just the kinds of things we were talking about this morning in shared decision making. And that physicians require more tools also to help educate patients. That's logical, because if you're going to explain mammography screening, it would be useful to have some of the materials we heard about from Germany earlier today that show in a visual form whether the risks and benefits so that people can make informed choices. But at least we're getting some attention of the physicians. And when we hold meetings in Canada now, our annual meeting, we also have very big audiences of clinicians interested in learning more. So patients, what about the patient side? So just like Consumer Report, we're trying to get the message across to patients, and we've tried to use humor. So here is one of the ways we try to indicate the concept that more is not always better. Maybe you don't eat hot dogs in Switzerland, they're terrible, and I heard the thing about sausages earlier, but in North America, we're into hot dogs, and this is the way we've tried to share the message in a little bit of a humorous way. We have this as a poster. We have washing machines that are overflowing with suds, someone trying to stuff way too much clothing in a suitcase to indicate that more is not always better, and get some humor and get people's attention. And so this, for example, along with the questions that Consumer Report, that Becca showed you from Consumer Report earlier, we've blown them up into posters, and we sent them to all of the 31,000 family doctors in Canada. And in many family doctors' offices, you'll see this hot dog with too much mustard and the questions that Becca asked, although in Canada, we don't ask about cost. So what about patient attitudes? Well, 30% of patients told us that they had recently had a test or treatment recommended that they did not think was necessary. 30%. So what did they do with it? A quarter of them did the test without discussing it with their physician. That's very interesting, that they didn't think they needed it, but they didn't want to question their doctor, or for whatever reason, they just went ahead and took that colonoscopy even though they didn't really want it. 50% said they asked their physician whether the test or treatment was needed. And then a really interesting number, I think, is that a quarter of patients almost just ignored their doctor's advice, but didn't tell the doctor. Those are all those patients that we write a prescription, we hand it to the patient, and the patient walks out of the exam room and ditches it in the garbage, because we didn't have that conversation to know that the patient didn't really agree or didn't want it. So these are the kinds of attitudes we're trying to influence. So what about how much unnecessary care? What's the baseline that we're working with, and what kind of impact are we having? So in Canada, we have an institute called the Canadian Institute for Health Information, and they have very good information in many of the provinces, like your cantons. We have 13 provinces and territories in Canada across a very big country. And what we found in this report, where they took 8 indicators from Choosing Wisely, just 8, was that up to 30% of the tests and treatments, this magical number, 30%, seem to be things that are done that don't fit with the Choosing Wisely recommendations. So let me give you some examples. So on this slide, there are 4 examples. And if you look at the back pain on the top, you'll see that in one of our provinces, a big province, Alberta, 30% of the patients with low back pain had either an X-ray, a CT, or an MRI. These are patients without clinical indications of neurologic deficits. In the bottom below that, you will see that 1 in 10 people over 65 in Canada, 1 in 10, get a long-term benzodiazepine or sedative for sleep. And these are drugs where we know from evidence that there's more harm than good if you use these long-term in patients over 65. So what you can see in the bottom corner, another one, 18 to 35% of patients who are very low risk, having having surgery. So this might be a young person having an inguinal hernia repair or a cataract removed, but 18 to 35% of them are getting preoperative tests like EKGs or chest x-rays when they're really not needed. So we collected 8 of these. I mean, to give you another flavor, in the top corner, 30% of emergency room patients that come in with minor head trauma are having a CT scan in Canada. And in the hospital, a large number, 23% of patients with delirium are having CT scans. So we feel that this kind of measurement as a baseline across Canada is extremely important to us because it's allowed us to tell many of our stakeholders, like the people in this room, this is an important problem in Canada. This is not a minor problem when you talk about these kinds of percentages of patients having unnecessary tests and treatments. So this report has formed a very important baseline and kind of a call to action in Canada. Not only have we found that these are high rates, but we've looked at the variation in practice. And I think understanding, as many of us do, the variation between different regions is very powerful in helping create professional competition. So this is the benzodiazepine example. And what you can see is the rates in our different provinces, with 10% overall getting these drugs. But in one of our provinces called New Brunswick, the rate is 25%. So 1 in 4 people who live in this province are getting benzodiazepines long-term over 65. So these kinds of variations have also fueled our ability to work on the problem. And you can believe me that the people in New Brunswick are trying to figure out what's happening in Saskatchewan, where only 5% of patients are getting this drug. And there are many interventions coming up to try and work on this problem. So measurement is key. But we also have learned that we need to share experience with one another about how to make an impact on this kind of utilization. And so what we've been developing with our community are toolkits. And typically what happens is a group of hospitals work together, or some family physicians, and try to figure out how to have an impact on something. And we work with them based on the literature about evidence of how to put things into practice to create toolkits that include a lot of information that you could use about how might you implement this, how do you consider the setting in which you're working, how might you measure your impact. And so these are all online in case anyone would like to see them. But you can see that one member of our team likes cute names. So we have things like bye-bye PPI for proton pump inhibitors, or why give 2 when 1 will do. And I'll show you some examples of the impact that some of these groups are having with this kind of approach. So this is going back to the benzodiazepines in the elderly again, less sedatives for your older relatives. And this toolkit is designed for hospitalized patients, because what we know is that patients frequently get started on benzodiazepines when they come into the hospital to help them sleep. and then they get discharged on them, and they end up being on them as an outpatient. So we wanted to interrupt that cycle. So a number of hospitals have worked on the initiation of sedatives in the hospital. And this is kind of what they've been finding. Their interventions were really education, both with the physicians and the nurses. A very important thing is in the middle there. We use the term in North America, order sets. So what that means is sometimes people come into the hospital and there's almost pre-printed or on the computer pre-entered orders, which include a benzodiazepine as needed at sleep. And a lot of hospitals have made excellent progress by changing these pre-ordered orders, these order sets. So this was another approach. They also did a lot of sleep hygiene education with the nurses in particular, not interrupting patients' sleep, to take vital signs, not turning on lights, having quiet in the hallway, sleep hygiene. And you can see that they really dropped the initiation of new benzodiazepine orders. And this has been sustained. And this is now being disseminated to quite a few hospitals in Ontario based on their experience, because it was a very simple intervention. Here's another example. A number of the recommendations in Canada talk about use of red blood cell transfusions. I know that when I learned to practice medicine in my medical school, I always learned to order 2 units of red blood cells if I was going to order red blood cells. In fact, I never knew you could order 1 unit of red blood cells. And quite a few of the recommendations say not to order blood at all if the hemoglobin is not low enough. And secondly, if you do, to give 1 unit and reassess whether the patient needs a second, unless, of course, a person is bleeding actively. So this is an example from 8 hospitals who did a very simple intervention. They basically looked at the orders that were coming in for red blood cells, and they screened them against the criteria of the level of hemoglobin and this 2 or 1 unit. First, they did it only from waking hours, 9 to 5, and then they put this screen in 24/7. And they have dropped the use of red blood cells in the hospital by over 30%. And what's really great about this example is here's red blood cells, which our society donates. So it's a precious resource. We know that there are many adverse reactions to blood transfusions from a variety of different mechanisms. So it can be risky to patients. And it's very costly to implement crossing and typing blood and hanging blood. And so I think red blood cells is a really great example of everyone winning if we don't use it when it's not needed. So I offer this as another example. And we have similar data in all of these toolkits that I mentioned to you earlier, which are all online. So then the other thing that I think has been very exciting is that we now are seeing traction in working across countries, and this is the report of the OECD. As many of you know, the OECD publishes something called Health at a Glance, and that is a report that looks at how we do in different countries around the world on certain health indicators. And I'll show you some of their work, but they incorporated 3 items from Choosing Wisely into the Health at a Glance report, and there's one coming out shortly, I think in November. They also published this report called Tackling Wasteful Spending in Health, and it was developed in preparation for a meeting that was held in January of last year of all the ministers of health from across these countries who meet every few years. And this is an excellent report. For the people who are in government in the audience or anyone else interested. It articulates really clearly the issue of overuse and also approaches to change. So, engaging with ministers of health across the world, I think can help us raise the awareness and make changes. So here, for example, I'm going back again to the benzodiazepines in patients over 65. And you can see that the OECD has presented a graph of where different countries are in comparison to one another. And of course, this again fuels that healthy competition. Like, I wonder whether Ireland is putting it in the beer, and that's why there's so much there. But we need to figure out how we can harness this kind of information to learn from one another, even at a country level. The same kind of variation I showed you in Canada. Here's another example from the OECD. This is the number of MRIs per capita in different countries. And it's not by indication. They don't have the ability to know whether they're appropriate. But you can see in this table that the Japan and the United States have just enormous rates of using MRIs compared to many of the other countries in the world. So these are the kinds of comparisons that are evolving. So that said, we have created with the Choosing Wisely international group that I mentioned to you earlier, a collaborative of individuals from a number of countries just to get going, from Australia, Canada, the Netherlands, New Zealand, and the United States, to try and start picking some common issues and work across our countries to see if we can figure out what are the best ways to influence this kind of overuse, and how do we compare with more detailed clinical information. So whereas some of these large administrative data sets don't allow us to look at things like whether there are appropriateness indications like low back pain and neurologic findings, in the smaller collaborative, we're trying to pick things where we can get more detailed clinical information from charts or from their data sets. And some countries, like for example, Australia and Israel, have very excellent clinical data, and we can draw on that to get deeper information about overuse. And so we've been working together to do that, and also to develop common metrics of overuse. So if you're going to measure it in Switzerland, why don't we use the same measurement tool in other countries, and then we can really deepen our comparison work. Of course, there are lots of challenges to doing this kind of collaborative measurement. There is a lack of standard metrics, like I mentioned, on these common conditions. Most administrative data sets in North America and some countries in Europe really lack clinical data. They're just the higher level. That's a problem in our Canadian data. Although in some things like drugs, we often have better ability to measure. And there really is variation in our ability to collect data across these different jurisdictions, but we're working away at it. The other thing I think is a very powerful tool, but not one easily done in some places, is getting data right down to the individual prescribing physician. I think, again, harnessing that professional competition, that if I know that Dr. Myers is doing better than me, then I really want to pull up my socks and try and do better than him. And so we can elevate our quality by learning from one another how someone is performing better. So just before I actually open it up for questions, I just wanted to tell the group one other thing, which isn't in my slide set, but people have been asking me about it. And that is about education of medical students. And so I just want to take one moment to say, we have been really actively engaging medical students in Canada. And this was not something we actually planned, but medical students came to us and said they were interested. And they created an organization called Choosing Wisely STARS, which stands for Students and Trainees Advocating for Resource Stewardship. And our medical students are extremely engaged in this. In fact, they have created a Choosing Wisely list of 6 things that medical students should question, including don't order a test solely to anticipate what your supervisor would want. And I see there's some clinicians in the audience that have done that. And so one thing that I really would encourage that might come out of this conversation today that isn't really on the agenda, but I just want to put it on the agenda, is that students are a great resource because they go back and can get engaged in their medical school and engage their faculty in this issue of overuse. And they may be another real opportunity for you to work on your culture. So with that, I'm going to stop and open the floor to questions, because I'm very eager to hear, what you're doing in measurement that you think we could learn from. and to answer any questions that I can.